applications for children as well. And so this will be a real treat for us. Kassa.
Thank you, Stephanie, for all your kind words. I really appreciate it. It's such a pleasure to be here. And I have to admit, to see so many people at the end of the AIUM staying and wanting to learn about contrast ultrasound, it's really motivating for all of us who are doing it. I'll be talking about some pediatric applications, but I can assure you these same pediatric applications are applied in adults for various stuff. And you can also use some of these for additional techniques in adults. So even if you don't have pediatric patients, the methodology applies to all. So bear with me and just don't be discouraged just in case you're not doing children. So the first part is about pediatric contrast-enhanced voiding urosonography. I just want to mention that at the Children's Hospital of Philadelphia, we have established a Center for Pediatric Contrast Ultrasound with putting different divisions of the hospital together. And that has received a generous support from BRACO. And in addition, we have a large group who do a lot of research, and all those listed there are research funding that we have specifically for pediatric contrast ultrasound. And I have to say, in my 30 years of career, I have never seen so much funding for pediatric radiology, but not for ultrasound, and especially pediatric ultrasound. So the advent of contrast ultrasound has really increased the chances to get more funding. And I really encourage you, those who are in this field, to look out for funding, because there are novel methods that you are trying to introduce. So in my department, there are a number of people involved in these, and I just want to thank just some of them here. I'm sure not all of them are here, and want to say thank you, and also including the referring physicians. So the objective of my talk is to really first outline the rationale for doing this exam, and then how to establish the modality and some future outlook. When you want to start this contrast-enhanced voiding urosonography, you need to justify to colleagues, to administrators, to the chief, and so on. So what are they? So one of the first things to remember, it's an alternative imaging without radiation. What are you doing? What you're doing is you are going to replace the current imaging modalities for vesicoureteral reflux. That is fluoroscopy, which is voiding cystourethropy. Even though we have reduced the radiation dose, it's having ultrasound means eliminating the dose. And also you're reducing the chances of having scintigraphy or radionuclide cystography. So this is a replacement without radiation. And this goes along with all our activities with Image Gently, where there are a lot of attempts to reduce or eliminate radiation in children. And along with that, I just want us to be aware. Usually, it's not only us who know about contrast ultrasound. It's the parents. And this is because of internet. Parents know. And parents demand. And I can tell you some of our patients come because they see it on the internet and they want to come and have these studies. And some come from far away, and that should not happen if such a modality is much more widely available. So that's important realization. So let me start off with a case of a 4-month-old female patient who came to an outside institution with fever for 4 days. Urine culture was done, and E. coli grew, and ultrasound of the bladder and kidneys was performed along with VCUG. Based on those results, the physician decided to put the patient on antibiotic prophylaxis. These were the outside images where they did a VCUG, and you see there is reflux. If you look carefully, there is what is known as the drooping lily sign. That means this is a duplex kidney. The renal pelvis is pointing a little bit horizontal or downwards. So it's reflux in the lower moiety. of the left kidney, and they repeated again what's called encyclic VSUG, which increases the radiation, and they filled again and emptied the whole bladder. At the end, the patient emptied everything. So that was the first study. Then 20 months later, the parents found out about contrast ultrasound, and actually they were patients at CHOP, and it so happened they were patients of the chief of urology at CHOP, and they told him, he said, oh, we need to do a follow-up VCUG. Then they said, no, we've seen that there is something with ultrasound. We don't want radiation for our daughter. We want the ultrasound. And we had already started doing that, but it was not the first colleague who was referring patients was not the chief of urology. So he called me up and says, oh, can we do this? Yes, I say we can do it. So that was really the entry of him into contrast-enhanced voiding urosonography. So we had this patient, and we filled the bladder with the contrast agent, and you see in real time how the bladder fills. We do an infusion, and then we flush it with additional normal saline and see it mixing very well. And then we go and scan the kidneys. We scan the bladder, right kidney, left kidney, alternatingly. And this is the scan of the left kidney, and you see reflux in the lower moiety. So this is for someone who does renal bladder ultrasound. This is really not a rocket science. It's just a recognition of the contrast. Now, with all the manufacturers making this contrast-specific modality much more sensitive, the subtraction of the background much more effective, the conspicuity of the microbubbles so much that the learning curve is really C1, do one pattern. Really, you don't need much. You see the reflux in the kidney. There is nothing subtle about this one. So there is microbubbles flowing into the, and then we turn the patient prone. You see in prone, it's also conspicuously seen, and this is the image from prone. You see even the patient is moving, the patient is breathing, you can still do the study. And when you compare it, you just turn the ultrasound image with the previous outside VCUG, you see you have the same result. So it was a grade 3 reflux, same result. So the parents were unhappy that there was still reflux, but happy that they could avoid radiation. And the urologist was very happy that we found the same thing, so decided to put her on antibiotic prophylaxis, and as I mentioned, avoided VCUG and radiation. In addition to that, we do get not only eliminate radiation, but we do get better diagnostic results. We do detect with ultrasound more reflux. I just put there more than 10%. That's depending on the machine, depending on the sensitivity of the machine. The reflux detection rate can go up to 40% more. So this is something we have to remember. We have a much more sensitive method. This was sort of a meta-analysis that was carried out where there were 30 publications, over 2,500 children included, over 5,000 pelviureteric units, because the duplex kidney were counted as 2. And in this case, a subset of them were compared with VCUG, still over 2,000 children. And you see all the diagnostic results with even taking VCUG as the reference standard is relatively high. And when you take the direct radionuclide histography, where there are fewer comparative studies, the results that you get are similar with sensitivity and specificity. It's still high. However, very important to understand is we don't have any other reference other than, let's say, the VCUG or direct radionuclide histography. It doesn't mean the reference is in reality the best, but we just use it because currently that was what as the gold standard was. But if you look in this study, the comparison of the ultrasound and the VCUG, in this study, it's a conglomerate of studies, the reflux was seen in the ultrasound in 19% alone, and reflux was seen in VCUG in 10% alone of the total 2,800 pelviureteric units. So there was a 9% more reflux on ultrasound than on the VCUG. However, the most interesting fact is that the majority of the reflux seen on ultrasound, 70%, 70, two-thirds, was grade 2 to 5, higher grade. But the majority of reflux missed on ultrasound and detected on VCUG was in 70% grade 1. Grade 1 is the lowest, is the less clinically significant reflux compared to grade 2 to 5. So what we are seeing is that we not only detect more reflux, but we are detecting higher grade reflux. We are detecting clinically more important reflux. That's what we are doing with the ultrasound. This is one other study where there was a 47% discrepancy in the detection of the reflux, where you had 47% more reflux seen in the voiding urosonography. And in this case also, the same higher grade refluxes were detected on ultrasound compared to VCUG. So there is no doubt there are thousands of children included, thousands of pelviureteric units, many publications. And the detection rate of the microbubbles is much higher on ultrasound. And I'm talking about, this is the era before you see all these machines. You know, all the machines we saw at lunchtime, they are much better than the machines that were used in this study. These have been now optimized. Post FDA approval of contrast, the companies found reason now to optimize their contrast-specific modalities. And I can only tell you in the last 2-3 years, they have put in so much more than they did in many years in the past. So the sensitivity of the machines is even better. So we are expecting even more higher detection rate of reflux in the future. Then we have to, in our departments, realize that we need to have this method just as a diagnostic option. Why is that necessary? Because there is increasingly point-of-care ultrasound. If you don't do it in your department, somebody else is going to do it in their department. That's something you can decide, but at least one has to be informed to know what happens. So contrast is not limited to radiology alone. There is point-of-care ultrasound in the ED, point-of-care ultrasound in urology, point-of-care ultrasound in nephrology. So they may be doing this also. So at least one has to be informed, either to provide this service or be cognizant. If you don't provide them, somebody else will be providing them. And we have to also understand, by doing this, we're adding some value. The convenience, the lack of radiation, and all that, the higher sensitivity, we're adding value to the examination, which is something that is now much highly desired. In pediatrics, and specifically with contrast-enhanced voiding urosonography, the comfort and ease when performing the study should not be neglected. There is significant difference. Why? Fluoroscopy is a big machine. Yeah, the parents cannot be hugging the child. They have to stand far away from the machine. Ultrasound is small. Parents can be next to the child can sit on the parent, the child can lie together with the parent, the child can pee sitting on a potty, and we have a nice potty with music. When the child pees, the music comes. It's really nice, and I really recommend you, and the kids love that. Or the boy stands and pees on a urinal. That is like physiologic way. It's very hard to do these in a fluoroscopy machine if you try it. It's just cumbersome. You can't do these things. So it's very comfortable to be able to do it in such a physiological way. That's why this is very helpful, and the parents are very like it because they hold the child. The child can be hugging the parents and crying while you scan from the back, you know? So these are important things not to forget. So how do you establish the modality? Now that you know there are justifications, and you can use this justification to inform your colleagues and chief and administrator, how do you establish? You need to have an ultrasound contrast agent in your department. So you can use different contrast agents. The only thing is there are 2 contrast agents that have been specifically optimized for reflux, optimized in a sense, meaning they have been tested with urine, their dose has been determined, the interaction with urine and the conspicuity with urine has been evaluated, and that is for Optizone and Lumason. And hopefully one day we'll do that also for Definity and get it also approved for this indication. And with Lumason, that has been approved specifically for vesico-urethral reflux. When the FDA approved the contrast agent, and they put in their leaflet, you should use a dose of 1 ml. So if I may correctly say, the FDA approved primarily based on the grounds of the evidence you provide and the current existing evidence. It's hard sometimes to approve things based on potential future things. So based on that, they said use 1 ml, inject 1 ml, and then scan and see whether there is reflux. However, what happened in between the FDA's approval, this is FDA approved it based on the literature before the approval. But once FDA approved it, what happened? All the ultrasound manufacturers were scrambling to make their scanners much better. So what happened is 1 ml, if you inject 1 ml into the bladder, it's sometimes way too high. So in 1 ml of Lumason, you have 500 to 600 million microbubbles. So 1 ml turned out so much so that you're getting acoustic shadowing because of too many microbubbles. So what we use is if you inject about 0.2 ml around that would be sufficient to inject it. Alternatively, you can use infusion, and that is especially for beginners easier to use. You can use 0.2% of infusion with normal saline. So you mix 0.2 ml of normal saline with 100 ml or 98 ml of normal saline and get a 0.2%, and that suffices. So just be aware 1 ml may be too high. And it's easier to start with small amount and add more if you have any issues rather than adding more, getting the shadow and waiting to get rid of the acoustic shadowing. Regarding the safety, we have to note that with a contrast administration, there is a need for catheter. And it is known that the bladder catheter, independent of what you inject into the bladder, may cause some symptoms that has been already shown in older studies like dysuria, wetting, and gross hematuria. So there have been a significant number of studies that have evaluated the safety of intravesical administration of contrast agents with over 7,000 children. There is a 0.8% of adverse events, and if you look at that, it's dysuria, transient macrohematuria, abdominal discomfort. All these that are listed are most likely due to bladder catheterization and not the contrast agent. And there are some animal studies have also shown there is no mucosal disruption or uptake of the ultrasound contrast agent when you do low MI scanning of the bladder for reflux. This study with over 1,000 children specifically and in very detail evaluated the adverse events related to reflux examination, and there was a 3.7% adverse event, which were all self-limited, and catheterization was likely, and that shows a high safety profile. So if you are going to start tomorrow with this, what are the indications? The first indication is just to evaluate reflux, then you want to evaluate urethral pathology, and lastly, a combination. And the most ideal patients to start with are follow-up studies. So you know you already did VCUG last time, do a follow-up study, that makes your life easier. Or girls' first reflux examination is easier to start because of the rarity or absence of urethral pathology. unlike in males. And then if your urologists do screening for siblings, that's something you may include. And lastly, boys' first reflux examination, where you need to evaluate the urethra too. The only contraindication is if you don't see the kidney or bladder. That rarely happens if a patient has severe scoliosis, sometimes due to myelomeningocele or otherwise. The setup is you can do the study in your fluoroscopy suite or in your ultrasound suite. It's possible to do it both. Yeah, we have done it in both places. It's just out of practicality. Who can catheterize? Where do we have space? And so on. But more important than the setup is it's very important to have the sonographers as the frontline examiners. Only that way you will be able to establish in a proper way the examination in your department. It is not the way we do it here. It is not led by doctors in the forefront. It's led by sonographers. So it's important to train the sonographers. And I can stand here and I am extremely proud to say that we have some 20 sonographers and everyone does it. And everyone does it this reflux study alone, and I just found out when I rotated, oh, I'm doing it alone, and said, oh, you just can come in when I'm ready. I was quite impressed. That's how they do it, and 20 of them do all the ultrasound examination, the reflux examination. One other technologist from fluoroscopy comes and puts in the catheter, and then they do all the exam on their own, and only one person is needed. So as I mentioned, after the bladder catheterization, which is a standard procedure, we use an infusion. We use a three-way stopcock, and then with the 0.2% infusion, we infuse. We want a homogeneous distribution in the bladder. And the ultrasound contrast administration, how to prepare it, has been nicely shown before, so I don't want to go into it. But the only thing I just want to mention, the volume of the bladder, the way we determine it in children is age plus 2 times 30 would give you the expected bladder volume and tells you how much you need to fill the bladder. The ultrasound modalities have also been described. So I will not go very much into the detail, but all these with the background subtraction, the dual modality, the color overlay are necessary. I just want to point out 2 pitfalls. One pitfall is when you have a subtraction of the background, you want to ensure that the background is not too dark, as you see on the left side. You have to optimize it to show at least the borders of the kidney, as you see in the bottom, the borders of the liver or kidney or spleen. That way you know exactly where you are. The other thing is what you see on the right is the renal sinus. If you do not do, if the gain is too high, you may have a shine through of the renal sinus, and that may be sometimes confusing with reflux. This is the top box on the outside, maybe thought of as a reflux. That's why it's important to reduce that echogenicity and have it dark so that when microbubbles come in, you will be able to see it and not confuse it with the renal sinus. So once we fill the bladder, we want to have a homogeneous distribution, no acoustic shadowing, and visualization of the bladder base and the retrovesical space. And once you have that, you're able to see like bladder diverticula. You see the outpouchings on both sides and also confirmed on the VCUG. A few things to remember is the normal saline we use to fill the bladder, we just have to make sure it's best not to use normal saline from glass containers. Glass containers are usually sealed under vacuum, so they are desaturated. And if you have microbubbles mix in the desaturated one, all the gas will diffuse, so avoid that. Luckily, there are not many options to have large volume of normal saline in glass containers in the US, but in other countries, that's a possibility. So please make sure to use only normal saline from plastic containers. Then injection should be only straight, and that has been shown to be important so as not to disrupt the microbubbles. Then we flash it from the side opening with normal saline to mix it. The dose, as I mentioned to you, has to be appropriate. The 1 ml dose in the leaflet may be too much. You may need to use less. We have to adjust the mechanical index to scan appropriately. In the US, due to JCO, we can only use 1 vial for 1 patient. 0.2 ml you draw, and you have to throw away 4.8 ml. I always cringe, but there is no option. In other countries, you may be able to use the vial for multiple patients. But just remember, even if you use 1 vial, that the microbubble effect, we did a study, doesn't change for hours and hours. So if you can open a 1 vial and use it the whole day, it's still effective, but you're not permitted by JCO to be able to use that. Just one thing to remember is if you have to do an MR or CT study, it's advisable to do the ultrasound first and then CT or MR later, because the CT or MR contrast does not mix well with the ultrasound contrast, and you may have such images, and you need a homogeneous distribution of the microbubbles to make the diagnosis. So as I mentioned, we scan the kidneys alternatingly, right and left. And then if you have reflux, if you scan in coronal from the flanks, you're able to see the reflux in this small baby on both sides very well. You also see intrarenal reflux on ultrasound. Look at the echogenic cortex. This is comparable to the VSUG. We're able to grade the different grades like the VSUG from 1 to 5. And this is also a poster we prepared to demonstrate with the newer techniques how it looks like, the different grades. And this is a composite image to show there is a similarity of the reflux grading to the VSUG. And we know if we compare the reflux grading, in the majority, in 3/4, the grading system in ultrasound and the VSUG is the same. In about 20%, the reflux grade in ultrasound is higher. And that is the main reason being that grade 1 reflux in VSUG in about 65% is grade 2 or higher. We also scan in suprapubic or transperineal, the urethra. Here you see a nice normal male urethra. There are normal values for the diameter of the anterior and posterior urethra. Here you see the urethra of a girl with reflux into the vagina too, which occurs very frequently with VSUG or ultrasound reflux study. And this represents a dilation of the posterior urethra, and so a patient with a posterior urethral valve. Here, an anterior urethral valve with the dilatation, nicely shown also on ultrasound. Just to demonstrate to you all the pathologies that you can see, or a urethral stricture, you can nicely depict. We even use it intraoperatively with the urologist to depict the strictures when they want to operate those. Or even like a Cobb's collar normal variant can be nicely seen on the ultrasound, or an ectopic ureter in the anterior ending in the posterior urethra is seen here, or a prolapsed intravesical urethral seal is nicely seen, or a prostatic utricle with reflux into the prostatic utricle can be seen. And this was a bladder neck dysfunction which bulged during voiding. So these are all demonstrating the utility of ultrasound and contrast ultrasound for diagnosis of urethral pathology. Just briefly, in the future, there's a possibility to do 3D and 4D for the reflux to depict it better, and also to use it intraoperatively, especially during deflux injection, and monitor the treatment and demonstrate and adjust the treatment accordingly. So contrast-enhanced voiding urosonography has high diagnostic yield, is very safe, and there are a number of emerging modalities. Thank you very much for your attention, and any questions? Yes, yes.
Are there any questions for that very nice presentation? Get your phone ready. Yes?
So the bladder, you fill it according to the maximum bladder capacity, age plus 2 times 30. Yes. Normally you start, you inject a little bit normal saline. You don't want to inject it in an empty, collapsed bladder. And then you keep on filling the bladder until you reach the maximum capacity. Yeah. So age plus 2, like if it's 5 years, 5 plus 2, 7 times 30, 200 ml, 210 ml. Yeah. Yes, please. Yes. So the sequence is you start with the bladder when you fill it, and then once you see it filled, once you have a distension and you can evaluate the retrovesical space, then you go to the right kidney, then in sagittal, right kidney, left kidney, and then back to the bladder to see that there's still contrast, and you continue. When you see reflux, it's good to depict it also on the coronal view lateral. Yeah, when you see reflux. If you don't see reflux, you don't need to do that. And then when the patient starts voiding, you want to see suprapubic or transperineal the urethra. And then once you see it well, you don't have to keep on watching the urethra. And then you go to the blood, and not to the blood, to the kidneys to see if there is reflux during voiding. Yeah? Yes? So we do both. So we scan the urethra and with the catheter, and then we remove it and scan. The same way we do the BCG. Yes. And then we scan the kidneys. You're right. Thank you.
Here, I'm going to get you to ask him later if you can, because we're behind a bit now. Okay?
Good. I'm available. Okay.